When we have a patient who has localized prostate cancer, there really are three main groups of types of treatment. One of the good things about prostate cancer is that 7 out of 8 men that have it live long enough to effectively die of something else. It's always a morbid thing to talk about what you're going to die of, but this is not a cancer that is universally lethal. And in fact, it's the minority of people that die of prostate cancer that are diagnosed. That being said, it really becomes a very personal choice when you're deciding what treatment to undertake. And the additional tests that have become available to evaluate your risk assessment is really important in helping men decide what to do. That's because one of the real options for men with lower grade prostate cancer, lower risk prostate cancer, is to do what we call active surveillance, where we decide we're not going to treat the cancer early on or immediately. We're going to monitor you closely, and at some point, if the cancer tells us that it's behaving more aggressively than we might think, then we might decide to treat you. And the reason being for this is that we know that prostate cancer, even when it's more aggressive, in many cases is still very slowly growing. So we feel we have enough of a head start on it in those cases to watch it initially and then determine if ever you need treatment. Thankfully, what we found is that many men that go on active surveillance don't eventually need treatment at all. So if you go into it knowing that you're at a very low risk of progression, it may be a choice that you make to decide to do active surveillance. There really are no strict guidelines for active surveillance. In general, I think most of us believe that a repeat biopsy sometime in the first year is helpful. We've started to use MRI technology, which has really developed in the past few years and allow us to see cancer within the prostate to make sure there's no more significant cancer that, for whatever reason, was missed in the initial biopsy. So we often are using MRI as well, and even being able to pair the MRI with newer techniques in how to do the biopsy to get a really precise biopsy of those areas. We generally recommend getting a PSA at least a couple times a year, and those repeat biopsies every 1 to 2 years after the first year. You hear terms active surveillance and watchful waiting sometimes used interchangeably, but really they do mean different things. Active surveillance, and the whole reason we came up with the term active surveillance, was because we do want there to be a continual observation going on. Generally, we'll be doing regular PSA tests, periodic rectal exams, and periodic repeat biopsies to make sure a cancer is not progressing. Watchful waiting is more of a hands-off approach, often in older or less healthy men who we've basically decided we're very unlikely to ever do any significant treatment for the prostate cancer. We may monitor the PSA test, and if it becomes very rapidly higher, then we may do some testing just to make sure it's not spreading, and then maybe treat based on the presence or absence of disease spread. But generally, we're not watching nearly as closely and as actively as we would otherwise.
In men with low-grade prostate cancers, many of those men, maybe most of those men, can just take the course of active surveillance. But if they don't have the psychological makeup, if they're nervous, if they're always going to worry that something's going to take off in this cancer and be a problem, those men may be better off being treated. But many men who are less concerned, who are thinking about this disease, that this is never going to bother me, they may be better suited for active surveillance. So there's a lot of factors you have to take into account.
Whenever we're talking about active surveillance or even attempts to cure prostate cancer through things like radiation and surgery, it's always talking about localized prostate cancer, cancer where there's no evidence of any spread elsewhere in the body. If there is spread elsewhere in the body, we don't think of it as curable, although it is still very treatable. Most of the discussion is around local or localized prostate cancer, early stage, and like I said, we feel we have a very big head start in most men. Unfortunately, there are some men that do present with advanced prostate cancer, and that's a different discussion, but once again, it's still very treatable. They're treatments designed to ablate the whole prostate, or essentially destroy the cancer in place. The most common of which is radiation. There are treatments designed to surgically remove the prostate, so that would be surgery, prostatectomy of different forms. And then there's active surveillance. When we talk about the radiation treatments, there are different ways to do radiation. There's external radiation, often with the use of image guidance through CT scanning and other things that allow us to be very precise in treating the prostate. But there are also placement of radioactive seeds within the prostate and various other ways to deliver radiation to the prostate. Another way to ablate the entire prostate is a treatment called cryotherapy, or freezing, essentially, of the prostate. It's not quite as popular as some of the others, but it is being used in low-grade, low-stage cancer. Radiation treatments are generally done by physicians called radiation oncologists. They're specially trained in radiation. Many of them will give radiation treatments for different cancers, although there are some specialized centers that just treat prostate cancer. Surgery is also done using different techniques. Traditionally, there was the open prostatectomy, usually done with an incision below the belly button to remove the prostate. In the past 10 years, the advent of robotic technology has led to a real change in how most prostatectomies are done. They're now done with the use of the robot, which is essentially using a less invasive approach, the same concept as laparoscopy that might be done for a gallbladder removal or an appendix removal or something like that, is now able to be applied with this new technology to the prostate. So the majority of prostatectomies being done now are done using that approach. Prostatectomy, or the surgical removal of the prostate gland for prostate cancer, is done by urologists. Once again, we are physicians, we're MDs, just like the radiation oncologists, with training more in the surgical approach, as well as the diagnosis and treatment of many other urologic diseases.
When I speak to a patient about their prostate cancer, already I know what their medical condition is. The patient with prostate cancer, many times in discussion with his family, then have to listen to what I say or what their physician says, and with the physician, they make an intelligent decision on what their treatment option will be. It is not a decision many times that the man makes solely on his own. Generally, it is always in conjunction with his physician, who gives him the treatment options, and many times with his family. It varies on what they choose. I believe second opinions are important for many things we do, but that has to be a personal decision. I believe when I tell a patient a diagnosis, I'm giving him information to the best of my ability.